Hi, I'm Dr. Poonam Hosamani, and today I'm going to demonstrate a 10-minute moment for knee pain. The 10-minute moments were created to help assess physical exam skills. They contain a faculty development portion and an assessment portion. Assessing and giving feedback on a learner's physical exam skills should be easily integrated into clinic flow or into rounds at the hospital. Taking a good history is essential and greatly aids in making the correct diagnosis. However, the 10-minute moment was specifically used to assess physical exam skills only. It does not include history-taking skills. Let's get started. This patient comes to the clinic with knee pain after a fall 3 days ago. Your learner is tasked with doing a physical exam to decide on further management. The initial step in evaluating a patient with any physical concerns is to observe the patient. Is the patient in obvious pain? Were they able to walk to the examination room, or were they using crutches or even a wheelchair? The next step is to do a structured knee exam. The structured approach to the knee exam includes inspection, palpation, range of motion, and provocative maneuvers. Now let's move on to the inspection portion of the exam. In this part of the exam, we'll have our patient walk, squat, and be able to observe their motions as they do all of these maneuvers. The first part of inspection is to observe the patient's gait with the lower extremities exposed. We could have our patient please walk and walk back. Thank you. An important part of this exam is to make sure our learner asks the patient to expose both of their legs and ask the patient to actually perform the gait maneuver, which can often be quite challenging. While the patient is standing, I ask them to squat down and to stand back up. If our patient could please do that. Thank you. If there's any pain that gets reproduced in the squatting motion, there's a good chance that the pain might be due to patellofemoral pain syndrome. It's also really important to observe the muscles as well as the skin of our patient. Is there any atrophy of the muscles? Is there any redness or swelling that we can observe by comparing both knees? Are there any bruises or wounds or perhaps any prior scars from surgeries? Those would all be important aspects of the inspection portion of the exam that would help inform a potential diagnosis. Let's begin with the palpation portion of the exam. For this part of the exam, we would have our patient be supine with their legs exposed and extended. We would ask our learner to be able to palpate for an effusion, for the anterior, medial, lateral, and posterior parts of the knee, and be able to assess if there's any pain in those areas. It's important to have an organized structure to the palpation of the knee and be familiar with the anatomic structures. We start first with checking for an effusion with a fluid wave or ballottement. So for this, we would try to assess if there was any fluid both superiorly and inferiorly to the joint, and then assess for ballottement. And as we're palpating different portions of the knee, it's important to ask if there are any areas of tenderness. You could also observe our patient's face to see if there's any indication of pain. I start with palpating the anterior structures, which are the tibia, the tuberosities, the patellar tendon, the patella, and the quadriceps tendon. Then I palpate the medial structures, which are the pes ansor and bursa, and the medial joint line. Tenderness in the medial joint line is suggestive of a medial meniscus injury. I then palpate the lateral structures, which you can see most clearly here, which are the fibular head, the lateral joint line, and the iliotibial band. Tenderness in the lateral joint line is suggestive of a lateral meniscus injury. Tenderness to palpation over the IT band is suggestive of an IT band sprain, which is very common etiology of lateral knee pain. There's really not much to palpate in the posterior part of the knee, but I do palpate for any potential of an aneurysm or potentially a Baker's cyst here in the posterior portion, depending on the structure of what I palpate there or the consistency. Now we'll begin the range of motion exam. First, we would ask our patient to actively flex and extend their knee. Great. For the second round, for passive range of motion, you would place your hand on the patient's knee and then flex and extend the knee for them while keeping your hand on the patella. For the knee exam, it's important that you examine both active and passive range of motion. With testing passive range of motion with your hand on the patella, you can feel for crepitus and patellar tracking. If a patient has crepitus and bony enlargement, there's a good chance that they have osteoarthritis. Let's begin the exam for provocative maneuvers. We'll start with the anterior and posterior drawer sign. The provocative maneuvers in general are meant to test the stability of the structures that are tested. It's a good idea to do a provocative maneuver that you think hurts most last, as the patient who's in pain will have a difficult time relaxing if they're feeling a lot of pain at the time. Also, it's important to do the provocative maneuvers on both knees so that you can detect an appreciable difference between the injured and the non-injured side. The provocative tests are less useful in a patient who comes in immediately after an injury with a very swollen and painful knee, because the pain and swelling might make it more difficult to do a good quality knee exam. Let's start with testing for stability of the anterior cruciate ligament. For this, you can perform either the anterior drawer test or the Lachman test. The anterior drawer is less symptom specific than the Lachman test. For the anterior drawer, we would ask our patient to bend their knee and place their foot at the edge of the examination table. In order to stabilize their foot, you as the examiner would sit on their foot in order to have it not move when you perform this exam. You would then place your hands behind the knee and your thumbs on either side of either the tibial tuberosity or the patellar tendon and make a quick forceful move forward. If there was a tear in the anterior cruciate ligament, you would notice that there would be laxity and there would be movement of the tibia forward. In someone who does not have an ACL tear, you would notice that there would be resistance to that movement and the tibia would stay in place. For the Lachman test, in order to stabilize the knee, you would place your own knee under the distal femur of the patient and then stabilize the femur with one hand while you place your other hand below the popliteal fossa. You now try to make a similar movement and moving the tibia upwards and forwards. Again, in a patient with an ACL tear, you would notice that there would be laxity when you tried to move the tibia forward. To test for posterior cruciate ligament tears, we would have a similar position of the patient as we did for the anterior drawer test, where we would have them bend their leg, stabilize the foot by sitting on the foot gently. And this time we would actually try to move the tibia backwards. Keep in mind that your hand positioning is identical to the way that it was for the anterior drawer. This time you would be pushing the tibia backwards. And in someone who did have a posterior cruciate ligament tear, there would be a significant amount of laxity and you would actually be able to push the tibia backwards. We'll move on now to valgus and varus stress, which can test for stability of the lateral collateral ligament and the medial collateral ligament. In order to do these maneuvers, you would lift your patient's ankle and have them flex their knee to about 30 degrees. You can also do this with the knee straight as well and see if there's a difference, and also make sure to perform it on the other side. In this movement, you would have, if you were to do the 30 degrees, you would place pressure on the medial side to test for lateral collateral ligament foot laxity, or on the lateral side to test for medial collateral ligament laxity. Notice if this elicits pain and how far the joint opens compared to the other side. And finally, we'll end with the McMurray test, which is a test that assesses for meniscal tears. Other tests that do this are the Apley test and the Thessaly test. For the McMurray, for the medial meniscus, you would place your fingers over the medial joint line and have your patient flex to about 90 degrees. You would then internally rotate the foot and have them extend their knee with your hand on the medial joint line as you come down. You're assessing for a clicking sensation as well as a reproduction of the patient's pain. You can do a similar maneuver for the lateral meniscus by externally rotating and placing that same pressure. Again, you're assessing for a clicking sensation and for reproduction of your patient's symptoms. Make sure that your learner does all of these provocative maneuvers as well as compares both sides. It's really important that the learner keeps the patient comfortable and explains the rationale behind the different exam maneuvers to the patient. A patient who understands why a certain maneuver is being done is more cooperative and satisfied with the exam. This concludes a 10-minute moment for the knee. Thank you for watching.